Good afternoon, everyone. I'm Dr. Liu Ming from the Department of Medical Ultrasonics, the first affiliate hospital of Shenyang University. Today is my great honor to be here and make a presentation about our CUS case, gastrointestinal hemorrhage or biliary tract bleeding. We used the CUS to find out the true killer. The first part is the personal profile. This is a male patient, 38-year-old. Present with hematemesis and hematoxia for 2 days. This patient 2 days ago had hematemesis about 1,000 ml for 3 times, and with deadness and fatigue. He also discharged dark red blood for 3 times, and then he was sent to ER immediately. The blood examination showed the HB decreased gradually to 57, which is severe anemia. Then he got an emergency gastroscopy at first. Found the duodenal mass ulcer with hemorrhage, but there was no active bleeding. Then this patient got an emergency plan CT scan. The CT scan showed there is a mass between the duodenal bulb and the pancreatic head, but the nature is to be determined. It also found the local dilation of the right bile duct, slightly high density inside it, maybe calculi, but further examination is recommended. So, is this really just a simple case of gastrointestinal bleeding? What is the mass located between the duodenal bulb and the pancreatic head? At the clinical routine, the patient got an ultrasound scan. The green ultrasound showed the common bile duct, and the right bile duct are filled with the solid echo. We also found the mixed echo mass between the pancreatic head and the duodenum, size about 5 centimeters with clear margin. The CDI-5 image showed there is no singular inside the mass. Then we injected the Sonovil to the CUS. The first we observed the mass located between the pancreatic head and the duodenum. There is no enhancement in the early and late phase. Then we do the second injection and observe the intrahepatic bile duct wall. This is hyper-enhancement in the early phase and hyper-enhancement in the late phase. But there is no enhancement inside the bile duct in all phases. The series image feature is like this. This is the target mass in the center. There's no enhancement in all the phases. You can see that. The stars shows the pancreatic parenchyma. It is iso enhancement in all phases. And we found there is the common hepatic artery behind the mass. It is hyper enhancement compared to the pancreas. This is our diagnostic thought. There is a mass with no enhancement. So first time we excluded the solid tumor of the pancreas or the bile duct. Maybe it is a pancreatic cyst. But when we concern to the clinical manifestation of this patient, and we found the key point, this mass has a blind end derived from the hepatic artery. Maybe there is a possibility of the arterial aneurysm with thrombosis inside it. Finally, we got our diagnosis of CUS. The common hepatic arterial aneurysm ruptured and thrombosed. The right bile duct also thrombosed inside it because of bleeding. Then we contacted the clinical department immediately and report critical value. The patient got a CTI scan immediately. This time, this diagnosis is clear. Common hepatic arterial aneurysm with mural thrombosis. And we can see this. This aneurysm is very clear in the CTA, and it is very large. We can see the right lobe and the common bile duct had high density inside it, also caused by the bleeding. See, the reconstruction of the aneurysm is very clear from the common hepatic artery. With the quick preparation of the pre-operation, the patient got the DSA of surgery. So the maximal diameter of the aneurysm is 3 cm, and the guide wire and the catheter was entered into the aneurysm within the locks. We can see that. After that, they did DSA again. The aneurysm was blocked off completely. The surgery was successful. Significance of our case. This case is about a hepatic arterial aneurysm. It is formed by dilation of HA and its branches. There is no literature reported HA aneurysm diagnosed by CUS. It is classified as extrahepatic and intrahepatic type. Involving part, the most often is the common hepatic arterial and then the proper hepatic arterial, and then the right and the left hepatic arterial. In our case, presents with symptoms of rupture into the duodenum. Patients presented with massive hemorrhage of upper gastrointestinal tract, and it is very emergency. This patient also ruptured into the biliary. We can see the biliary with mixed echo inside it, but the symptom is not very obvious. This emerging sign was first detected by CUS. So CUS played a decisive guiding role in subsequent examination of this patient, and the patient can get quick, no delay with the surgery treatment, and finally he recovered well, successfully. So that's the end of my presentation. Thank you very much.
Thanks, Dr. Liu Ming. Now we would like to have Dr. Tang Shaoshan to comment, please.
Thank you, Dr. Liu Ming. Very good presentation. And this case is an emergency case. CUS played an important role in diagnosis. In this case, no enhancement in lesion and intrahepatic bile duct. This evidence can help us to rule out malignant tumor and tumor thrombosis. So you give me a very good cases.
Thank you.
My question is that, as you know, CUS is also widely used in emergency physical medicine. Please give us 2 examples and describe how to diagnose them on CUS.
Emergency case, you say?
Yes, emergency.
Emergency case. Sometimes patient, if patient got the HCC resection after the surgery, we can find there is a mixed echo mass, maybe a mass, just in the area of the surgery. But when we do the CUS, we can see there is no enhancement. So we think maybe just the fluid in the resection area. This one case. Another case maybe. Let me think. Emergency. In the
activity bleeding.
Yeah. In the abdominal trauma sometimes we can see the spleen, the liver has trauma inside it, or out the parenchymal, or in the parenchymal, or out the bowel movement. So we can see there is no enhanced by the CUS. Maybe just the fluid or just the flood, just the blood after the trauma. So it's abdominal trauma. It is useful to use CUS.
Thank you.
Thank you very much.